And before we start off, I request Dr. Jayashree to address all of us and tell something about the college.
Good evening. Good evening, Dr. Radhakrishnan, and good evening, Dr. Meenakshi, Dr. Parthasarathy, and Dr. Balachandar, and Dr. Vineet, and Sanish, and everybody who's attending the webinar. Welcome to the webinars series that the Indian College of Anesthesiologists have been holding for the last 3 years. We'll be celebrating our 4th annual ICA webinar very soon next month. These webinars, for your information, are being conducted religiously every Wednesday at 7 o'clock. No change in time at all. And the feedback that we get is that the students are really enjoying it because it is screened on the YouTube later on. So some students who do not get time to hear it today, they do it later on. So that's a big achievement, and we are really actually proud of it. Coming to the Indian College of Anesthesiologists, as you know, this is an academic institution where we promote all the hospitals and the colleges and the institutions to promote academics. And in fact, gradually, we have got over 1,000 members, about 1,500, 1,500 members or more than that. And there are many fellowships that are going out in different cities, like the liver transplant and thoracic surgery in Medanta. In Gangaram Hospital, we have the very popular Indian Diploma of the Regional Anesthesia, the ultrasound guided blocks, which is very popular, and it's going on these days, and next week will be the examination. And this is a very popular one in the south, and we have onco anesthesia from Hyderabad. So several others which you can find on our internet. The annual conference will be held in September. This will be the 15th national and the 5th international conference, going to be held in Lucknow in the KG Medical College. Again, you get the details on the website. And the New Delhi PG Assembly that we are starting for the first time, just like the New York PG Assembly, this will be held in July, mid-July in Delhi. Of course, the seats are all full, but any student who's really interested can contact any one of us. So with these few words of introduction of the Indian College of Anesthesiologists, Dr. Meenakshisundaram, thank you so much. And please start the webinar, the moderation. Thank you.
Madam, thank you very much. At the outset, I thank the Indian College of Anesthesiology for having given me this golden opportunity to moderate 2 top people. Now it has been added as 3. And first of all, I'm very happy that Indian College of Anesthesiology is conducting webinars continuously for 4 years. So with this, what I feel as an overview of diabetes mellitus, I want to say a few points. Diabetes is a catabolic phenomenon. But in the anesthesiology and the surgery, they are also catabolic phenomena because the glucocorticoids increase, all the blood glucose level increase, the catabolic effects, but we want an anabolic effect. Already diabetes mellitus, insulin secretion is diminished, and because of the surge in counter-regulatory hormones like glucagon, your glucocorticoids, everything, they produce a catabolic phenomena. So the paradox is we want an anabolic phenomena. They reduce insulin secretion further. So Dr. Parthasarathy has to throw light on that. And the diabetes mellitus affects all the organs, and it can create even a multi-organ failure within seconds. Another point which most of us fail to note, there is an entity called accelerated physiologic age. That means if my age is 30, if I am suffering from diabetes mellitus, that is type 1 insulin dependent, my age is considered as 1.75 if it is not controlled. That is, it is equal to 52 years of age. And if it is well controlled, it is equal to 1.25 times. So the physiologic aging, accelerated physiologic aging is possible in diabetes mellitus. And in the preoperative management of diabetes mellitus, the blood glucose level is not only important, it is the end organ damage. So that should be a truth, one of the truth Dr. Parthasarathy is going to expose. And unfortunately, the control of diabetes mellitus See, it is there are so many varieties of controlling the blood sugar in the perioperative period, because it depends upon the type of diabetes mellitus. It depends upon the type of surgery. It depends upon the type of the bias of the primary physician. And most of the times, if an anesthesiologist is getting an expert opinion from a diabetologist, it is gone. So totally they will be diverted, and they will be end up in management of micro levels of albuminuria and this diabetes mellitus, even for a accession of lipoma. So Dr. Parthasarathy has to throw light on that. And the worst thing is diabetic ketoacidosis. At any point of time, the patient can end up in diabetic ketoacidosis, and routinely for postgraduates, the question will be infection gangrene leg posted for weak amputation in a state of diabetic ketoacidosis, whether you will proceed or not. This is a routine question which will be asked in the examination, and management of diabetic ketoacidosis is going to be an essay question. And just to discuss that, he is coming on a case-based discussion, Dr. Balachandar. So we are going to have a sweet feast from Dr. Parthasarathy and his younger colleague, Dr. Parthasarathy. Already they have introduced him. He is having only 6 alphabets in his name. But if you see his degree, it will come to 36 alphabets. So I need not introduce Dr. Parthasarathy. If I introduce Parthasarathy, it is going to be a one lecture. So that lecture we will have some other time. So I request Dr. Parthasarathy to come with the perioperative diabetic care, the truths behind it. Over to Parthasarathy.
Thank you very much, sir. So already he has told the Bhagavad Gita and all, and he has told so many things which puts unnecessary stress to me, whether I can always tell all the truths or some falsehoods, or shall I expose all falsehood. All these things have come to my mind now. So now, sir, Meenakshisundaram sir, if something goes wrong, don't worry, I will adjust. Okay, sir? Okay. Now, the declaration is, so this was actually asked for it, and I will do this. Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries. Professor Ravi Shankar was produced more stalwarts in anesthesia. No, I thought why I should choose this topic. Because my style cannot change, whatever it is, ICA, our routine class or whatever it is. My style comes like that only. So somebody will enjoy, somebody may not like this, like that. So there is a gap between what is needed and what is given. Now, I may not be talking much on big evidences or big journal 2024. I will give some evidence and some experience and mingle it or merge it. Now, you take up this scenario. A 62-year-old male on oral hypoglycemic drugs, and his random sugar was 185. So he was admitted for surgery. On admission, it became 380. Was started on insulin, Actrapid 6 units at TDS by a physician, and it was reviewed after 2 days, and 2 days later it was 300. 380 has come to 300, and it was increased to 8 units TDS. And know what is the surgery? It was cataract. So that is why I am telling there is a big gap between what is needed and what is being prescribed. So whatever it is, I have to go from A to Z, like, no? So because A to Z coverage is very difficult, I will shorten it and give whatever the truths. Inadequate supply of insulin or inadequate tissue response. The insulin is not coming out, or when the insulin come out is not acting. This is a basic thing. So it gives out to a lot of complications. Normally we get polyuria, polyphagia, polydipsia. That doesn't occur in many cases. It comes as genital itch, loss of weight, but increased appetite. And many times we do a lot of diabetic camps in a school for community people. That time the teacher tests, the headmaster tests, they become diabetics. So it is an incidental finding in many times. India is a diabetic capital, and the condition is very worse because our control in our study of 200 patients in single day in Kumbakonam, the average HbA1c was 8.9. So it's not controlled, and India is the diabetic capital. Whenever you talk something, you have to talk the types of diabetes. Immune mediated. You have an immune related damage to the pancreatic beta cells. That is what is called type 1. It is not immune mediated, but there is a deficiency or there is a resistance. It is type 2. The others are because of thyroid. This is Modi is a maturity onset diabetes of the young, then the gestational diabetes. So now we are going to concentrate more on type 2 diabetes, which is very common, more than 90%. There is some vague phenomenon. Somebody will say insulin dependent. Somebody will say insulin non-dependent. That is what is called type 1 and type 2. It's not like that. Whenever there is immune problem, it is type 1. Immune problem is less, then it is type 2. Even in type 2, they may be insulin dependent. So we are going only to type 2, whether it's insulin dependent or OHA dependent, whatever it is. What is the diagnosis? How will you diagnose diabetes mellitus? The Balachandar, my speed is okay?
Yes, sir.
Okay.
Yes.
Symptoms of diabetes, for example, a polyuria with an RBS, random blood sugar of 200, or a fasting blood sugar of 125 plus, postprandial of 200 plus, or a HbA1c of more than 6.5. These are the classical diagnosis, because it is not like a skin lesion. We cannot diagnose like this. We have to depend upon blood tests in diabetes mellitus. So pre-diabetes is 100 to 125 and also about 200, 140 to 199. It is all about plasma venous glucose. This is one of the first important truth we should know. What all we diagnose is plasma, it is venous, and it is glucose. Now we go. The arterial and capillary blood yield glucose values 7% higher than venous blood. Whole blood determinations are usually 15% lower than plasma values. The capillary blood may vary whether it is fasting or postprandial. These are certain small things. There may be variation of 5 to 10% with regard to. But whenever you diagnose 125 plus, 200 plus, it is all about plasma. It's all about venous glucose. This is a surgical, this is hyperglycemia. Surgical stress can cause pancreas to cause reduced insulin production, relative insulin resistance, and hyperglycemia. This adipose tissue, increased lipolysis, also causes hyperglycemia. So this is all about counter-regulatory hormones. That's what Dr. ALM is telling, and hyperglycemia. Now we had is already having surgical stress. We had another some type of counter-regulatory hormones because of anesthesia and produce more of hyperglycemia. That is what he told as catabolic. Now the treatment schedule is lifestyle modifications, drugs, and insulin. In the drugs, we have biguanides like metformin. Metformin is banned. Metformin is very simple. Metformin is to be continued. Those things about lactic acidosis have gone, and we need to continue metformin preoperatively if we plan 1 minute, sir. Hello, meeting like our 40 minutes sketch. Metformin. And we have glitazones, pioglitazone, rosiglitazone was there, and sarglitazar has come now. Secretagogues, sulfonylurea, and non-sulfonylureas like repaglinides. Agents that absorption, carbohydrate problem, alpha glucosidase inhibitors, they call us oglibos now. So these are all some of the drugs which can cause, which are useful for this thing. Now you have old drugs. Metformin, continue. Sulfonylurea may be stopped. Pioglitazone has got two problems. One is they are prone for fractures. We don't know what is the exact mechanism of pioglitazone. So don't use beyond 60. And another problem with pioglitazone. Number one is weight gain. Number two is cardiac associated edemas may be there. So pioglitazone is absolutely not to be used in such patients, old age, or whenever you think edema is a problem, whenever you think weight gain is a problem, or whenever there is some cardiac problem, just stop pioglitazone immediately. Now we have a relatively new drugs, SGLT2 inhibitors, DPP4 inhibitors called gliptins. These are called gliflozins. We have other drugs like imigliptin, semaglutide, and colesevelam. Now I will tell what is incretin effect. This is very important because when you take oral glucose, when you are taking oral glucose and make your sugar as 175 milligrams, this is one scenario. Another scenario is you give IV glucose and make the blood sugar as 175 milligrams. Now you see, oral glucose people will have more insulin production. This is what is called incretin effect. If you take orally and produce the same glycemic profile as IV, the oral route person will have more insulin secretion, and this is called incretin effect. This is because of incretins. Now, there are incretin analogs, there are DPP4 inhibitors. Now, these are incretins. These are destroyed by DPP4, and these DPP4 inhibitors are called gliptins. We can directly give incretins or we can give DPP4 inhibitors. They are called gliptins. They are very good. Sitagliptin, vildagliptin, alogliptin, linagliptin, saxagliptin. Except alogliptin, I have used all. It's okay for the heart. My article is there, sitagliptin and heart failure. Liver is okay, brain is okay, kidney is okay. Stomach, there may be some problem, some dyspepsia, maybe there. A minimal bloating on initiation. Now you see the most important truth about gliptin. It can take unconnected with food intake. That is what anesthetists want. If you want food intake and drugs, then it becomes a problem because we are not for food intake and anesthesia. So that is the big advantage of gliptins. Can be continued through the perioperative period. Now there are problems with NSAIDs and beta blockers and gliptins, so that should be taken care of. Now we are saxagliptin, linagliptin, all these things are gliptin. This is DPP4 inhibitors continued throughout the perioperative period. We will come to the next class of drugs, gliflozins. Now this is SGLT2 inhibitors, sodium glucose co-transporter 2, and one is here. Here, now what happens is, this is necessary for sodium. This is a lumen, urine. Now sodium comes in and glucose comes in. If you inhibit this, sodium goes out, glucose goes out, and also water goes out. So sodium goes out, glucose goes out, and water goes out. So that is how it decreases blood sugar. Now there are a lot of drugs like dapagliflozin, empagliflozin, Remacana. All these 4 drugs I have used. Air2 and Soda I have not used. So it makes us Dapachek, Empacare, all these drugs, Remo. So many companies have come out with these drugs. So gliflozins, what they do, they cause sodium loss, they cause sugar loss, they cause water loss. These 3 things. Anytime in diabetes, it is independent of insulin. There is no relationship about insulin resistance, all these things. It causes weight loss. Sorry. BP is less because we know water is going, sodium is going. Lipid profiles are better. When sodium goes, water goes, cardiovascular morbidities may be less. But the problem is there is a volume loss, there is a sodium loss, there is a potassium loss, urinary infections, especially fungal infections. It is a nightmare for urologists. These drugs are a nightmare for urologists. There is a risk of hypoglycemia. There is something called euglycemic ketosis. Now people have started using gliflozins for non-diabetics. How we can assess post-operative fluid assessment, because this will go, water loss will be 1 liter or something like that. Now, it can decrease insulin. It can increase glucagon. What sir has told, this is some sort of catabolic. So surgery is a catabolic. So whenever you see these things, you should stop gliflozins 3 days prior, and there is absolutely no urgency to start again. So the another truth is stop gliflozins 2 days before. Now you see that is what is called SUPCAR, sodium glucose transport associated perioperative ketosis. Now you see these patients, sometimes if it comes, they are not stopped for 2 days. They may develop abdominal pain, nausea, BP fall, normal glucose values, because it is euglycemic acidosis. So what happens when this happens in postoperative day 1? after a laparotomy. Think of us. We will never think of this euglycemic ketoacidosis by a gliflozin, but we will be thinking of what happens to the surgeon, what happens to the laparotomy. So whenever this patient has gliflozins, they are not stopped 2 days or 3 days before. Whenever they get these things, we need to check acidosis, acetones, etc. Plasma ketones should be done post-operatively. Yes, sometimes from Vande Bharat, we may go to the cold chain crane. So that is what we need to check urine glucose in these patients who have not been stopped. Gliflozins have not been stopped. Yes, cholecystazole is a basic bile acid sequestrant. It is useful for this thing, sugar level decrease, and also for acystatin. But the problem is it has to be given with a meal, something like this, anesthesia and this thing. So we cannot this thing. So we need to stop the drug, and there is no urgency to restart. And imiclamin is a wonder drug, what I feel. I have used in around 500 patients. Now, 500 milligram TDS, it strikes the exact problem, the mitochondrial dysfunction of diabetes mellitus. 500 milligram TDS will start. Absolutely, I don't find any major side effect like diarrhea, whatever it is. So, the drug is not very potent. That's one thing. It doesn't decrease HbA1c from 8 to 6.5. But continue the drug. Nausea, vomiting is less. No effect on volume status. No effect on life. And there is no effect on this thing. Aspiration risk. Now, semaglutide is a human analog of native GLP-1RA. The incretin, no, that's what I've told. The incretin inhibit pandra DPP4 inhibit pandra the gliptins. Incretin straight we can give. The starting dose is 3 milligram once a day for 1 month, can increase later. The problem is increased gastric contents, high risk of aspiration. People are using it even for weight loss. So, full stomach RSI, ultrasound gastric content, all these things should be done. So, that is a problem with semaglutide. You may need to stop this semaglutide, preferably 6 to 7 days prior. That is another truth. If the patient on semaglutide, stop this. The advantage of this semaglutide for us is one tablet costs 480 rupees. That is a big advantage. That is why we don't get commonly this drug into anesthesia. If this comes down to 48, everybody starts semaglutide, and that should be stopped 1 week prior. And they should go, all elective cases should go for RSI. There are other drugs like this, and we will go to insulin. Now we have the bicarbonate on hepatic, glucosidase inhibitors. This is on pancreatic, and this is on this thing. So, when the insulin was first derived from pigs, it was called porcine, and cattle, it was called bovine insulin. And these insulins were slightly different from human insulins, and they started human insulins from yeast by recombinant DNA technology. Human insulins has got A21, B32, or something like that, A chain and B chain, the amino acid sequence. That is what is produced by recombinant DNA technology. That is what is your actrapate, conotar, and all. Now we have analogs. Analogs means one amino acid is changed. For example, proline, one amino acid is being substituted by lysine. That is what is called lispro. Then you called asparagine is changed. That is what is called asparg. All these things are short-acting insulins. This is only place where we go from digital to analogs. So this is 15 to 30 minutes. Regular insulin is called oral actrapate. This is glargine is a long-acting insulin. It starts by 1 hour and it is 24 hours. It comes as Lantus. So there are a lot of mixes. Lispro with Aspart with Degludec. There is one more long-acting. That is what is called Lysodac. Degludec. This is NPH with Lispro. That is what is called Novomix. So many combinations are there. And you see, this acts by 1 hour and finishes by 3 hours. If you have a combination of Lispro with NPH, that is called Novomix, then you start see here actions. It comes down and it peaks here. Innumerable combinations. Now you come to you for pre-op. This is my experience about, and there is some evidence. Whenever you say diabetes mellitus coming for surgery, major surgery means the patient cannot take his normal diet within 24 hours. That is major for diabetics. Food intake within 24 hours is minor surgery. Okay. Now you think what I will again repeat major surgery. So major plastic surgery is not major diabetes. Food intake more than 24 hours, it's major in diabetics. Food intake within 24 hours is minor for diabetes. Sometimes 6 hours. So now, when to switch over to insulin? This patient is coming. When to switch over? All type 1 diabetics, they have on the insulin, you continue insulin. All type 2 diabetics, OHA is taken for poor control coming for major surgeries. Type 2 diabetes. Major surgery matlab, the patient cannot go to oral diet in 24 hours. Poor control, type 2 diabetics, major surgery, switch over. Well controlled major, optional. We can go with oral drugs only, shots of insulin during the operation, go back and then take food and then go for drugs. Decide on case-to-case basis. Because minor surgery, they may tell, because the patient is food in hernia. It's a minor surgery. But irreducible hernia, we don't know. Because sometimes they will have gut and they will push the gut and they will say, don't give food or water for 48 hours. Then it becomes major. So minor surgery is hernia and content is intestine and push something and they do all these things, then it becomes a major surgery. That is what is very important. Control or get it controlled. We start with sometimes insulin, a human active rapid acting insulin 6 units TDS and monitor 6 units in the night. Check blood and change the afternoon dose. That is what I told in the first slide. 3 days later is only for outpatient basis. If the patient is inpatient, check the afternoon dose and slightly increase from 6 to 8. So many times we see Rajani movies. What is the role of heroine? Many times there may not be any role. So whether HbA1c has got this role or not, that is what is the doubt. If people take HbA1c and make unfit or fit. Now you take a scenario. If A1c is 7, well controlled, but RBS is 325, will you take for thyroidectomy or MRM? No. Okay. Now what is the relevance of HbA1c? There is no relevance. Now you take another scenario. HbA1c is 8.5, but RBS is 150, fasting is 90, postprandial is 140. Posted for lab query, it is fit. So why we are very worried about HbA1c matlab? It just tells we may face end organ damage, as Dr. ALM has told. HbA1c is going on for 8.5, then we may be having a lot of end organ damage. So another thing is, if you see most common in trauma, you get injury and you get a hip fracture and your RBS is 250. But A1c is A6. This means that is injury-related stress diabetes. That is one use of HbA1c. So otherwise, HbA1c role is not very important like an current blood sugar role. But we need to have HbA1c in the mind because we will face end organ damage. So whatever as told is wherever the artery goes, NLM has told it has CAD, cause CCF, peripheral vascular disease, hypertension, CVA, CRF, neuropathy. This is chronic. So many organs. They may be dehydration, impaired wound healing, infection, worsening spinal cord ischemia, hyperviscosity with thrombogenesis. I will tell you, we have published one article. What popliteal sciatic nerve needs for a block in diabetics is only 6 ml. That is what we have published. Minimum effective concentration, ED95, is only 6 ml. Dr. Bala knows, he is also a co-author in that. So we did an up and down study and found out that 6 ml is enough for good anesthesia in the foot in diabetics with neuropathy. Think of it. Now we usually give popliteal sciatic 20 ml. But because of this, we need only 6 to 8 ml in popliteal sciatic. So this has to be understood. This is another truth with this. We all know the prayer sign, but it doesn't need to be, because if that is a gap there, then you are likely to have problems with head and neck flexion, and your intubation may be problematic. I have already told coronary artery disease, nephropathy, retinopathy, dyslipidemia, and neuropathy. Now, that is why we should take ECG, creatinine, X-ray chest, peripheral neuropathy, and autonomic neuropathy. It's very important. Now you see, this is very important. Put a hand on the pulse. The pulse should be tuck, 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 like that. There should be some variation with breathing. If it is showing tuck, 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 this is what is called fixed tachycardia. This is a sign of autonomic neuropathy. Put a hand on the pulse and wait for some time. In patients with diabetes, this is another truth which I want to tell. So even the surgeons should see to that this is done, and see whether there is an autonomic neuropathy. Because I usually always tell, if you see child, you are a pediatrician. If you see old age, you are a geriatrician. If you see only eyes, you are an ophthalmologist. If you see autonomic nerves, then you are the anesthetist. That is what I usually tell. Why we are worried about? An intraoperative BP4 is more, arrest is more, an exaggerated response to intubation. They will go for hypothermia. They will not know hypoglycemia. The ventilatory response to hypercarbia is less in the postoperative period. If the carbon dioxide piles up, you will not have an increased tidal volume, whatever it is. So these are all the problems of autonomic nervous system. This has to be the most important truth that is necessary to be very much given importance. So now we know the nature of the diabetes and its treatment: insulin dependent, non-insulin dependent, what drugs to be stopped, end organ damage. So sulfonylurea need to be stopped a day prior. Metformin can be continued, glutens can be continued, and gliflozins have to be stopped, semaglutide has to be stopped, and imiglamin can be continued. This is about, we should know what is the duration of fasting. Time available for improving control. I'll come back again to this. Now, where do we stand in electrolytes? Because we are worried about early morning electrolytes on the day. At home, he is on insulin BD. Who checks electrolytes? He is on insulin BD for years together. Nobody checks electrolytes. Then really, do we need to check electrolytes? Yes, the basis is, if we have a basal potassium value, we can contemplate on insulin infusion. And if the patient develops arrhythmia after an intubation response, we will know that, okay, potassium is normal. That is the main use of going potassium value. Many patients, it's not necessary to switch over to insulins. Stop OHA on the day of surgery. That's what I told. Gliflozins 2 birth, surgery is ketogenic. That's what he has told. And these drugs are also ketogenic. Take a morning sugar. If the patient is on long-acting, larging, in a commercially called Lantus, or degludec, commercially called Tresiba, insulin Tresiba, the patient should take 2/3 of the Glargine dose and the entire Lispro dose. For example, Lispro is a short-acting. Lysine is changed into proline, changes into lysine. This is Lispro, short-acting. So short-acting should be given full, and Glargine should be given 2/3 in the night. So hold all morning dosing. Hypoglycemia episodes can reduce up to 50%, then regimens. A hypoglycemic patient, if that is going to be there, then 2/3 level, we can come down to 50% of the Glargine dose. So many times we need not go to customs. Okay, now this thing, we are on Glargine, newer, analog insulins. No, you have to change over to Actrapid and Monitor, nothing like that. Cut down on the Glargine dose by 2/3, continue Lispro on the morning, see the blood sugar and start your insulin regimens. So it is not necessary that we should switch over to common routinely used atropine and monotard in all cases. Let the glargine be there. Let the degludec be there. All these analogs, long-actings. There is one study which tells even 400 is acceptable, but we don't accept above 280. There are a lot of regimens. There is some regimen called no glucose, no insulin. A pre-existing glycemic control is good. For example, his sugar, random sugar is 160 and his A1C is 7.1. And minor surgery is planned, hydrocele, orchidectomy, something like that. Breakfast and oral agents are omitted in the morning. Dextrose infusion nil. Check blood glucose. Then after the surgery, give the oral food and give the drugs. This is what is called no insulin, no glucose regimen. There is one small problem with this. As Dr. Meenakshisundaram has pointed out, if we don't use glucose and if we don't use insulin, some sort of ketogenesis from non-carbohydrate sources will be there. Protein will change into glucose because we are not doing glucose. Fat will change into glucose. This is somewhat catabolic. We want glucose to protein in the surgery period and not protein to glucose. But minor surgeries, this is okay. This is classic non-tight regimen. What we do, this is not to have a tight regimen of 80 to 100 or 100 to 110. It may be 130 to 140 or better, preferably below 180 in the intraoperative or perioperative period. The aim is to prevent hypoglycemia. NPO after midnight. You see, so this is the most important problem here. We just tell in the morning list, night no, don't take any food. But at what time he has taken the dinner, it must be 8:30 p.m. So it is preferable to have some juices or something in the midnight. At 6 a.m., start 5% dextrose at a rate of 125 ml per 70 kg. It comes to around 16 drops. But some patients, if we don't want to give so much of fluid, we can take 10% dextrose with 50 ml per hour per 70 kg. So that comes to 8 drops or 9 drops. Then we started. After starting the intravenous infusion, give the half the dose of morning dose. For example, he's taking monotard 10 and actrapid 10, give 5 subcutaneously, and then continue the 5% dextrose solution and give continuously and till the surgery is over. This is non-tight regimen. What we do, NPO. At 6 a.m., we start 10% dextrose, 8 drops. Then give the half the dose of this thing. If the patient is in sepsis or on steroids, we can take little 2/3 of their insulin doses and then continue the drug. We have given subcutaneously. So it will act. If, for example, you have done monotard, it is going to act for some 12 hours. So that will take care of your perioperative glucose control. And then afterwards, you monitor, and the so-called original sliding scale has come. But the problem with sliding scale is you have to know the surgery. It cannot be continued for days together. Minimum or 6 to 8 hours. We can continue with sliding scale of this. You get around 200, give some 6 units or 4 units IV and get till this procedure is over and your perioperative period is sufficient to be satisfactory. Switch over to oral diet or switch over to your previous insulin and then give. A small technique I do for periphery practitioners. What I do is morning 7 a.m. I give 5% dextrose and then give the mixed insulins or no mix. Then I'll give NS in the afternoon. And then again give 5% dextrose in the night at 7 p.m. and give this mixed. This is equivalent to morning and night oral diet and giving. This is what I do in certain cases where it is difficult to monitor every hourly prick. And this is equivalent to what they do at home. But divide weight by 4 for basal and prandial insulin. This is Miami formula. Now, weight is 60 kg. 60 by 4 is how much? 15. 15 is the basal dose, monotard. 60 by 12 is 5. That is actrapid. 5 and 12. This is non-tight regimen. What is tight control regimen is we have to be very testing at 80 to 120. Our problem is not hypoglycemia. Mind hypoglycemia is there, but we have to have this thing, especially wound infections and cardiopulmonary bypass. Now, many people start on the evening before surgery, but it is practical to start in the morning of surgery. Determine the preprandial blood blood sugar and start your dextrose and your insulin in a saline intravenous infusion at 50 ml and then piggyback with saline with insulin. And check blood sugar 430 and then check with some insulin increase, or since this saline is piggybacked here and this is the dextrose which is going at 50 ml, and increase insulin infusion start and keep it around less than 100 or 150 maximum. That is what is called tight control regimen that has to be continued post-operatively. There are a lot of other regimens, value regimen, GIK regimen, so many regimens, but you should know 1 unit is likely to decrease by 25 milligrams and better to keep it around 140 to 180. Intravenous insulin is preferable when there is a shock patient or hypothermia, because peripheral vasoconstriction. We are not very interested in subcutaneous absorption. Then we can give 6 units or 4 units IV. And we should know 1 unit, 25 milligrams. There is GIK solution, glucose, insulin, potassium. 500 ml, 10% dextrose, 10 milliequivalents, 10 units of insulin. Start at 100 ml per hour. 1 line. Then other line, if there is blood loss, we can give saline. If there is something else, we can give oral. So this has to be 10% dextrose. Some people say 5% dextrose. I prefer 10% dextrose and come down on the rate if you want to 10 units. Sometimes we prepare 1 GIK 15 units, 1 GIK 5 units, and 1 GIK with 5% dextrose, depending upon the case. This looks little complicated. There is one problem, because insulin pushes potassium into the cell and it causes hypokalemia. But surgery causes potassium to release. So there is a contradiction. So not much of this market hit this regimen is because of this. But who does operations at 8 a.m. many times? We start cases at 2 p.m. We start cases at 2 p.m. and afternoon list will go on. And what I do is take a breakfast and take the insulin, probably 75% or 2/3 of it. Take breakfast at a little less, not full hefty breakfast like this, little less. If you are routinely taking 4 idlis, take 2.5 idlis and then give a 75% dose of insulin and then do the list. Because already we have done 7 o'clock, we have finished this thing and monitor blood glucose. The practical solution of the afternoon list. Yes, many of the physicians don't know whether colon wash or bowel wash is given. It causes lot of fluid changes. So only we know. In fact, yes, already we have told, other than any heart dysfunction, we have to see autonomic nervous system. No anticholinergics, you have to document neuropathies, beta blocker, okay, atorvastatin, we have already told, gastroparesis. So preferable to have metoclopramide and pantoprazole as or ranitidine as pre-medication, and this is very important. And the fourth truth is all document our neuropathies. AC inhibitors depends upon what is the thing. AC inhibitors continuation or discontinuation is a big thing. That's a different topic. Now regional, general and post-operative pain relief, and think of glycemic profile. There is one problem. Now I have got one patient with BP was rising in diabetes after spinal also. Spinal also after it was rising. So I thought, what is the problem like? Actually, the patient's sugar was 70 and 65. So low sugar, high BP is a combination. Sympathetic nervous system stimulation. Unless the autonomic is completely bold, it is going to cause this. So whenever there is high BP in diabetics, think of low sugar. There is another truth which I want to tell. Think of end organ damage. Yes, regional anesthesia may be sometimes beneficial because PONV is less, airway problem is less because, prayer sign is a problematic. Earlier mobilization, if you give a good popliteal static nerve block, we need not give opioid because autonomic neuropathy, hypercarbia, less response. So we give less opioid is another truth about diabetes, and reduced hospitalization. Yes, any drug is okay. Etomidate is okay. Ketamine is also okay. Propofol is okay. Benzodiazepines, surgical catabolisms. Continue infusions till oral diet and to keep around 150 milligrams. And after diet, change into pre-op schedule. Whatever be the pre-op schedule. Pre-op schedule may be oral drugs or insulin. Total insulin requirements, very simple it is. If the insulin requirement, we know preoperatively we have stabilized and it is 50 units per day. Now, 50% long acting at bedtime and the remaining doses now, we know 50 units per day is his requirement. Divide 50%, 25 units monitor in the night and 25 at rapid, give us 888. This is how we should give so that basal, nutritional and correctional. Somebody will tell, what is this? How we are doing? We will get into hyperglycemia. That is why evidence has told correctional. Basal is basal. Nutritional is in between the food, before food. Correctional is what? Whatever mistake we have done, we have to correct. So after all this 888 and 925, the sugar is 280. We give correct another 5 units IV at the time, subcutaneous at the time, and change your subcutaneous according to the next day. That is what is called correctional. What matters in the post-operative period? Mostly you have to review preoperative and intraoperative. Metabolic impact of the procedure, presence of pain, infection, adequacy. Many times we do a perianal abscess. The abscess is drained. So your insulin requirement will come down by to 60% of whatever it is. You are requiring 20 units, then we may require 12 units. That is, if the pus is drained, your infection, your requirement will be low in the post-operative period. That only we know. Physicians may not know. We know that infection is cleared, pus is cleared, your requirement will come down by 60%. Now we will go to scenarios. We will see some scenarios. By the time 1 minute, I'll take some fluid. Very nice scenario. And I think this is. Now we have diabetes mellitus, 30-70 on mixed-start. Mixed-start 30-70. Mixed-start means actrapid is 30% and monitor long-acting is 70%, 15 units and 12 units subcutaneous PD. Your RBS is 194. We are coming for gastrojejunostomy. Gastrojejunostomy means the patient will not go to normal diet in 24 hours. It becomes a major surgery. So, preoperatively, you continue this and preferably you go to tight regimen. 75% dose, you start a 5% rest dose, piggyback your actrapid and maintain around 100 to 150 till the patient gets into oral diet or a right tube feed, go back to your 15-0. Now you have seen two. Diabetes mellitus, RBS is 198. Glimepiride with metformin, the patient is on. Now we should know what is the surgery like. Surgery is herniorrhaphy. Simple. Minor surgery. We'll take oral diet. So, stop oral drugs. Monitor sugars. In the night, give some oral diet and also the drugs. That's all. Don't sit out insulin, all these things. Because minor case, well controlled with OHA, don't shift to insulin. Diabetes mellitus on OHA, gliptins, fasting is under. Now we know oral hypoglycemic drug is there. Fasting is well controlled. Go on gliptins. Gliptins matter, we can continue these drugs, not gliflozins. But for CABG, there is lot of temperature changes, lot of hemodynamic disturbances, so many things are there. So there is no question of gliptin or anything. Switch over preoperatively to insulin and start tight control regimens. Now, scene 4 is diabetes mellitus with RBS of 350 on oral hypoglycemic drugs for. Now, TERP is a problem because sometimes there may be big hemodynamic disturbances. Nowadays, there are too much of laser and all these things. They are things. Stabilize preferably on insulin pre-op and may carry out with non-tight regimens also. What is non-tight regimen? To start 5% dextrose or 10% dextrose, 50 ml per hour, and give the dose, preferably 65 to 70% of it subcutaneously, and go back to sliding scale preoperative, and go back to a preoperatively. What is the insulin preoperative? Diabetes mellitus with ANS involvement on OHA, but well controlled. This patient is coming for 4 hours of plastic surgery of the hand. It's a minor surgery. Because the patient will take the diet in the night. The patient is diabetes, OHA, well controlled, ANS involvement is there, monitor, give a block, whatever it is. Continue OHA, and sometimes we can do a non-type intra-op control or no insulin, no sugar, take OHA after the food. Now this is a problem. Total abdominal hysterectomy, well controlled on OHA. Major case, well controlled, optional. I have told optional. Well controlled, OHA, major, optional. Not necessary to shift to insulin. We can go oral drugs and continue with a non-tight regimen intraoperatively and finish the case. Go back to OHs after 1 day because sliding scale can be continued maximum of 1 or 2 days. Now the problem with physician, I'm again telling, truth number 5 or 7, whatever it is, I don't know, I'm not counted. A lot of gut adhesions and manipulation of the gut went on intra. The physicians will not know. Post-operatively, they will see the blood sugar 225 and write 8 units or 10 units. But we know there are a lot of gut adhesions. Surgeon has come, manipulated the gut. They have put the raised tube and this patient is on NIN oral. And we should be careful about sudden diabetic ketosis in these cases. Strict control of these things are there. OHA is not possible. Go back to insulins. Go back to sometimes infusions or BD or ectopic TDS with monotard HS. There's another scenario. Elderly female had a fracture rib with random blood sugar of 385. Coming, if it is semi-emergency. I was never a diabetic, sir. No, your report is wrong. So that time we can push insulin rapidly. That is where the HbA1c comes. HbA1c is 6.2. Okay, this fellow is telling, the patient is telling the truth now. Correct truth now. Get fast into control, get electrolytes, preferably below 200, and get the surgery done. Now there is a diabetic foot amputation. I think that is will be more clear with Bala. RBS is 350. Yes, I always prefer to wait for 4 hours. These type of emergencies. We can give up to 0.2 units per kg or 0.7 units per kg according to other things. Whether the patient is sick, whether the patient is having sepsis, whether the patient is on steroids, whether the patient is having a clear proven insulin resistance like obesity, obstructive sleep apnea, then this patient will need 0.7 units per kg. 70 kg means he may need 50 units per day. Now, scene 8 is diabetes mellitus, OHA, lab coli, uncontrolled. Major case, uncontrolled. Switch over to insulin. And then stabilize non-tight insulins, the regimens. Now, what is the message? Look for sugar control, acute and chronic complications. Stop glyphosins. Talk to physicians what we want. When to switch tight or non-tight. Look for end organ damage. And always keep an eye on autonomic nervous system. Thank you all. Thank you.
Thank you.
Hello.
Thank you, Dr. Parthasarathy. See, the questions and the discussions will be at the end of the second lecture. So now I request Dr. Balachandar, Associate Professor, Mahatma Gandhi Medical College, to deliver the lecture on diabetic ketoacidosis.
JIPMER, sir, switch it over to JIPMER.
JIPMER, yeah. Anyway, he's putting up that biodata. So he has to cover it on a case-based discussion. Over to Dr. Balachandar.
Thank you, sir. Respected moderator, senior professors, Partha sir, and dear friends, good evening to all of you. I am here today to present on the topic diabetic ketoacidosis. Before going to that, how it is relevant to us. See, as Partha sir was saying, the prevalence of diabetes is on the rise, and we are getting many diabetic patients for the surgery. And therefore, we have to have a controlled perioperative management, isn't it? So, am I audible?
Yes, you can proceed.
Yes. So, in that case, these patients are at risk of diabetic ketoacidosis. So, these patients can present with precipitated DKA either preoperatively or intraoperatively or postoperatively as well, due to various inciting precipitating factors. And therefore, we must be able to recognize its signs and symptoms and initiate the treatment appropriately, because any delay in this treatment is going to cause life-threatening complications and perioperative morbidity and mortality. Now, what is diabetic ketoacidosis? So it is a most common form of hyperglycemic or diabetic emergencies. Remember, it is hyperglycemic, it is life-threatening, and it develops within hours or at least over a day. So it can be seen both in type 1 diabetics and type 2, predominantly in type 1 diabetes, but with the increasing prevalence of type 2, especially with the excess catabolic status or stress where the counter-regulatory hormones are high, again DKA can happen. So these are some of the conditions wherein the catabolic stress is going to rise and DKA is going to get precipitated. And how it is diagnosed, the characteristic features are hyperglycemia with a blood glucose of more than 250 milligram per deciliter and presence of ketones in blood and urine, that is ketonemia. Blood ketones more than 54 milligram per deciliter or 3 millimole per liter is a significant. And the presence of high anion gap metabolic acidosis, which you assess by venous pH and bicarbonate levels. Now, with this, we can identify the severity as well, like mild, moderate, and severe. Now, what is the critical pathophysiology that is going to cause? As I said, diabetic type 1, there is complete or absolute insulin deficiency. In type 2, there is resistance. And along with the stress factors, there is going to be rise in the counter-regulatory hormone. So what is going to happen is, it's going to initiate a metabolic pathway opposite to that of insulin action. The cells will not be able to utilize the glucose, cellular starvation happens. And as a result, what are the metabolic pathways that are getting activated? In muscle, glycogenolysis happens. That is for glucose. Then proteolysis happens and the amino acids enter the liver, and which promotes increased gluconeogenesis. And in liver also there is increased glycogenolysis. And on top of that, insulin deficiency is going to contribute to lipolysis, which promotes free fatty acid levels in the blood, gets transported into the liver, where it induces the ketogenic pathway. The two ketone bodies are acetoacetic acid and the beta-hydroxybutyrate. And in addition, with lipolysis, the prostaglandins are released, which is essentially responsible for the vasodilatation. So the major pathophysiologic features with the DKA are the hyperglycemia and ketoacidosis. These two are responsible for the development of the clinical features. As you can see here, the clinical features as discussed before, polyuria, polydipsia, and with DKA, there is shock, altered mental status. Patient can present with predominantly 60% with nausea, vomiting, and abdominal pain, and Kussmaul breathing secondary to ketosis and acetone breath. So the abdominal pain, again, it's a suggestive of more of severity of acidosis rather than hyperglycemia. So these findings are due to the deranged metabolism, causing metabolic acidosis and electrolyte imbalance and volume depletion secondary to hyperglycemia. This forms the clinical triad of diabetic ketoacidosis. Now, how are we going to make the diagnosis? So it's very simple. As we said in the first slide itself, it is the blood glucose level with urine analysis and blood gas analysis. That is high anion gap metabolic acidosis. In addition, we should do other investigations as well to identify the precipitating factors as well as the metabolic derangements to further manage these patients. Now, one point I would like to show here is, during the urine analysis, most of the times we will check urine ketones. However, it is not a reliable marker for monitoring diabetic ketoacidosis. It says that there is a ketosis. However, in diabetic ketoacidosis, out of these two ketone bodies, the beta-hydroxybutyrate predominates, especially as the patient becomes dehydrated or becomes more sick. The NADH is getting converted to NAD, and this equilibrium, this redox equation shifts to the right, and beta-hydroxybutyrate predominates. And the urine ketones, what we are testing is sodium nitroprusside, which measures only the acetoacetic acid, and therefore we may not be able to quantify the beta-hydroxybutyrate or the severity of the DKA. In addition, it also shows false positive test results with AC inhibitors patient's sulfhydryl group captopril. And therefore, nowadays we are having ketone meters where the direct assay of beta hydroxybutyrate is possible with the capillary blood. So far, it is very straightforward in making the diagnosis of diabetic ketoacidosis, isn't it? But there are some subset of patients wherein the patients presents with ketoacidosis, but with the normal glucose level or glucose below 250 milligram per deciliter. Who are they? So these are subset of patients presenting shortly after receiving insulin, or a type 1 diabetic patient who are starving and vomiting, patients with impaired gluconeogenesis, as in cases of liver failure and alcohol abuse, pregnant patients, and as Parthasarathy has already mentioned, patients with sodium glucose cotransporter inhibitors. Because he said that there is how this drug causes euglycemia is it promotes glucosuria, and on top of that, it reduces the insulin requirements in the body as well as increases the glucagon levels, which predisposes to euglycemic diabetic ketoacidosis. Now, coming to the management, how are we going to manage such patients? Before going to the clinical scenarios, I said these patients can present incidentally intra-op, periop, pre-op and post-op, and therefore the main management is the aggressive fluid therapy. Resuscitation forms the initial treatment and volume repletion should be done. This should be followed by the initiation of the insulin therapy to reverse the metabolic consequences of lack of insulin. Now, then the correction of electrolyte imbalances, acid-base imbalances. Why? Because while doing the insulin IV therapy, this monitoring of electrolytes and acid base should happen, and accordingly your therapeutic management is going to change, which we'll see in the further slides. In addition to this, we also should make efforts to recognize and treat the precipitating causes and measures to prevent complications, because these resuscitative measures also can cause further complications with respect to DKA, which we'll see in the last slides. And don't forget to have the supportive measures in indicated patients where airway protection and circulatory support are needed. So this is another, another form I have depicted. So where I would like to focus the continuous monitoring of sugars and electrolytes of metabolic derangements during the therapeutic measures are very important. Especially blood glucose should be monitored hourly, and pH, sodium, potassium levels should be monitored every 2 hourly, and accordingly the treatment should change. Now, as I said earlier, these patients predominantly present to us for emergent surgery, as in cases, because many of the precipitating factors are surgically treatable, and therefore, do we have any standards or time frame for emergency care of such patients? Yes, we do have by the Royal College of Surgeons. What they are suggesting is patients, except for the patients with ongoing hemorrhage who require immediate surgery, all patients should be optimized before going ahead with the surgery with correction of hypovolemia, metabolic acidosis, and electrolyte imbalance. Now, we will discuss the management based on the case scenarios. The first case, a 24-year-old lady with history of type 1 diabetes on insulin therapy and 10 weeks amenorrhea, presented with history of vaginal bleeding and abdominal pain for 3 days, progressive shortness of breath for 1 day. A diagnosis of incomplete abortion was made and scheduled for emergent DNC. On examination, she was dehydrated, dull, but arousable with and following simple commands. Her heart rate was 128 per minute, BP 90/46, and respiratory rate is 28 per minute tachypneic. So this clinical setting of type 1 diabetes on insulin therapy with an acute illness and shortness of breath and dehydration is suggestive of clinically we can make a diagnosis of diabetic ketoacidosis. However, when you are called to assess these patients, what are all the information would you like to gather? Always try to identify the type of diabetes and control status. In this case, it is uncontrolled and precipitated DKA. Also, assess the associated comorbid illness. Why? Because these patients will, it determines the prognosis of these patients and influences the further management as well. Especially the elderly patients with comorbid illnesses have poor prognosis with DKA, and also ask for any prior episodes of DKA as well, and inquire about the diabetic medications and its adherence status, because in this case, probably she may not have properly taken the insulin therapy, which could have been one of the precipitating event. Also inquire for and evaluate for the precipitating factors. Here in this case, it's an acute illness. That's an incomplete abortion, which could have possibly precipitated. So there are several other similar conditions which would have patients present, like perforated appendix, gangrene foot, DKA patient, diabetic foot patients, and several such cases can present to us in the emergency. Now, out of all this, and like from previous lecture, do not forget to assess for micro and macrovascular complications associated with the diabetes in this group as well. Now the investigations have come to you. So you have noted that blood glucose is more than 250 and urine ketones are positive, and blood gas showing an acidosis of 6.9 pH, which is anion gap of 48, high anion gap acidosis, serum sodium levels low, and potassium on the lower side. How are we going to manage? As I said, the first principle or the first cornerstone of management is IV fluid management and resuscitation. So in DKA, you expect a volume deficit of up to 10 to 15%, which is around 5 to 10 liters or 100 ml per kg can be seen. And therefore, intravascular volume replacement is the cornerstone. Now, how does the IV fluid therapy is going to help us? It lowers the blood glucose level, it improves the glomerular filtration rate, tissue perfusion, and lowers the ketones by enhancing ketonuria, and improves the response to insulin. However, which fluid to use and at what rate? So that's the question in hand right now. See, the recent studies have said that normal saline is conveniently better for resuscitating the DKA patient. Even then, balanced crystalloid solutions can also be used. But however, its utility in critical care patients, resuscitations have been found, but not specifically with DKA patients. And what is the rate? Next, do not forget, never use a hypotonic saline for that is half normal saline for resuscitating this patient, because that will precipitate cerebral edema, which is one of the complications of DKA. At what rate should we give? The guidelines have mentioned 15 to 20 ml per kg in the first hour. But how are we going to do? Are you going to individualize this treatment, or are we going to give this for entire group of patients? Now, the general principles are, first you calculate the free water deficit using this formula, and then replace the 50% of the total water deficit in the first 12 hours and remaining 50% in subsequent 12 hours. This could be one of the strategies, or else you administer 500 ml increments up to a maximum of 15 to 20 ml per kg in the first hour. Another approach is give 4 ml. This is a very conservative approach, 4 ml per kg bolus, and look for the response. It's one of the fluid challenge test. In places where the infrastructure is good, where you have the advanced hemodynamic monitoring, better use the dynamic indices for guiding therapy in patients with underlying renal and cardiac dysfunctions, wherein you will aggravate the condition. So how we are going to give? Initial resuscitation, 1 liter per hour for the first 2 hours, or until the hemodynamic stability is achieved. Once BP normalizes, you decrease the rate to 250 to 500 ml per hour. Then simultaneously, you are checking the electrolytes every 2 hours, right? If corrected sodium levels are elevated, so remember I have mentioned here as corrected sodium levels. I'll tell this in detail in the coming slides. So the measured sodium level and corrected sodium levels. If you found it elevated, then you add 5% dextrose here with half normal saline. Otherwise, do not use half normal saline for resuscitation. And once the blood glucose becomes less than 250 milligram per deciliter, you can use 5% dextrose to the fluid therapy at the rate of 150 to 250 ml per hour, and continuously monitor the fluid therapy and adjust the therapy for urinary losses, because many studies have found that if we do not replace for urinary losses, the correction of electrolytes and the required metabolic derangements are delayed. And also continue the maintenance fluids. After the correction, continue maintenance fluids until the patient is able to take orally. And measure blood glucose hourly and serum electrolytes and venous ABG every 2 hourly, and renal function test 4 hourly. Now, coming to the insulin therapy, what insulin we should use? The treatment of choice is IV regular insulin as the continuous infusion we should use. and initiate therapy after starting the volume correction, and only when the potassium is more than 3.5. You should have the potassium value in your hand before starting the insulin therapy. In the presence of hypokalemia, do not start insulin therapy, as it's going to aggravate hypokalemia and it can cause fatal cardiac dysrhythmias. And maintain the blood glucose. That is our target here, 150 to 200 milligram per deciliter. And continue your insulin infusion until the DKA resolves, and plan for transition to subcutaneous insulin once the patient starts taking orally. See, the point here is there is no role for sliding scale. There is no role for variable rate insulin infusion. Here, with the DKA management, we are using fixed rate insulin infusion based on the body weight. So the strategy here is you give an initial bolus of 0.1 to 0.15 units per kg bolus. See, here there is a higher end of 0.15 units, which you reserve for patients with higher insulin resistance, obese patients, patients with sepsis, infection, patients, type 2 diabetic patients. So this group of patients, it should be reserved, followed by an infusion of 0.1 units per kg per hour. And hourly, you should monitor the blood glucose level. If the expected blood glucose change is 50 to 75 milligram per deciliter per hour, that is the expected change that you should have. And in that case, you continue the infusion at 0.1 units per kg per hour. If the blood glucose change is more than 75 milligram per deciliter, more than expected, suppose from 300 it has suddenly become 150 or something, then you have to half the infusion rate. In those cases where there is resistance, the blood glucose change is not up to the expected, less than 50 milligram per deciliter, then you repeat one more bolus with 0.1 units per kg and continue infusion, or you straight away increase the infusion by 1.5 times. So that can be done. Once the blood glucose level becomes less than 250 milligram per deciliter, you change the infusion to 0.02 to 0.05 units per kg per hour. And never forget, you add D5 in the IV fluid therapy as well. Now, coming to the potassium correction. Before going to the potassium correction, I would like to tell you that there are some pitfalls in the measured potassium values. What you normally expect in DKA is a potassium deficit, a total body potassium deficit due to the renal losses. However, the measured potassium levels will show you normal or elevated. Most commonly, that will be the clinical picture. Why? Because of the extracellular shift of the potassium due to acidosis, dehydration, and insulin deficiency. It can happen, it can be decreased as well, which usually happens during the correction of your therapy, hyperglycemia with insulin therapy, and acidosis as well. Now, how are we going to correct potassium now? Suppose the potassium initially, if you have a potassium deficit or hypokalemia, then in that case, you supplement potassium at 10 to 20 milliequivalents per hour and hold insulin until the serum potassium is more than 3.3 or 3.5. If renal insufficiency or the patient is oliguric, then in that case, withhold or decrease replacement. Make sure that during potassium replacement or evaluation, continuous cardiac monitoring should happen. If the initial presentation is normal, between 3.5 to 5, you can add 20 milliequivalents of potassium per liter of your fluid therapy and continue monitoring the therapy, potassium levels. If it is hyperkalemia, more than 5.5, it is suggestive of profound acidemia, renal insufficiency, and volume depletion. In that case, you obtain a ECG and check for signs of hyperkalemia. Do not give potassium supplement, though you expect a deficit in DKA, because it might precipitate fatal arrhythmias and potentially life-threatening. Now, coming to correction of sodium levels. Again, there are pitfalls with respect to measured sodium levels. How it happens? What you normally expect is there are renal losses of sodium and sodium deficit is expected. However, measured sodium will show normal or hypernatremic because of severe hemoconcentration due to volume loss can show it as a hypernatremic condition. And also you should remember that hyperglycemia itself factitiously lowers the serum sodium levels, and therefore we have to apply a correction factor to the measured sodium level. You add 1.6 milliequivalents of sodium for every 100 milligram of glucose above 100 milligram per deciliter So this is the formula for the corrected sodium, and with that you make the interpretation. Now what happens to the other electrolytes like calcium, magnesium and phosphorus? With similar to sodium and potassium, the other electrolytes are also in deficit with respect to DKA. However, whether we are going to manage, no. Hypophosphatemia, it usually gets corrected with volume correction similar to sodium, and there is no established role in DKA management. Only if it is acute, if the levels are less than 1 milligram per deciliter, then you start the IV phosphate therapy. And for hypomagnesemia, if less than 1 millimole per liter, you give 2 grams of magnesium sulfate over 1 hour. And monitor this phosphate, magnesium and calcium level. Have a baseline value. At the time of admission itself, you have a value, and then you monitor or repeat the value every 24 hours for further management. Now, do we have any role for bicarbonate therapy in this group of patients? Routinely not required. Give only if the pH is less than 6.9, because with bicarb, soda bicarb, there are more dangers than good efforts. So we can give 100 milliequivalents of soda bicarb with 20 milliequivalents of potassium for 2 hours, can be given as infusion, or you can add the same 100 milliequivalents to the 400 ml of sterile water with potassium, and we can give like 200 ml per hour over 2 hours. So it may benefit selected group of patients, especially when the patients with refractory hypotension, severe septic shock, or patients with myocardial depression secondary to acidosis. There are several disadvantages with the bicarbonate therapy. They worsen hypokalemia, they cause hypertonicity and sodium overload, and precipitate cerebral edema. So the goals of our treatment. So in this case, are we going to take up the case immediately? No, we are going to follow the management or the resuscitation measures as discussed above and wait until these changes happens. Predominantly, acidosis correction takes more than 24 hours. So our aim here is to reduce the blood glucose less than 250 and correction of electrolytes, and go ahead with the procedure. After correcting the hypovolemia, we can go ahead with the procedure. So how was this patient management? After 4 hours, patient clinically improved with a blood glucose of 185 milligram per deciliter and pH improved up to 7.2 and a bicarb of 16. After which we did the case under sedation, IV sedation, and it was over. The point I would like to make here, as Partha sir has already told, the same line of management should continue intraoperatively as well as the postoperatively. Here again, do not switch to variable rate insulin infusion. Until the diabetic ketoacidosis is corrected, do not shift to variable rate insulin infusion. Stick to fixed rate insulin infusion and continue the resuscitation as well as the electrolyte corrections. Now coming to the case scenario 2. Here we have a 55-year-old male with a past history of type 2 diabetes on oral hypoglycemic agents present to the post-anesthesia care unit after undergoing surgery for open fractured tibia following an RTA. No head injury. However, the patient complained of abdominal pain and the attending nurse noted increasing drowsiness since admission and call you. And you found that the patient has tachycardia, BP of 90/50 and tachypnea, dehydrated, blood glucose of 286 and urine ketones positive. So as I said earlier, DKA can present in the postoperative period as well. Again, the management principles are same. You follow the same principle, resuscitation, start the resuscitation with IV fluids. So the diagnosis, when you are making the diagnosis, it's a metabolic acidosis because the change in the pH is 7.2 and the bicarb is 10, are in the same line or low, and therefore it's metabolic acidosis. Now calculate the compensation PCO2, 1.5 times the bicarbonate plus 8 plus or minus 2. It is 23 plus or minus 2, which is the expected value. In this case, it is 25. So it's a pure metabolic acidosis, is it not? Now calculate the anion gap, which is 23, suggestive of high anion gap metabolic acidosis. So in the setting of diabetes with elevated blood glucose, positive urine ketones, it is suggestive of diabetic ketoacidosis. And in addition, you measure the corrected sodium also as with respect to the formula. Measured was 131 and corrected was 134. Now management, same, IV fluids, initiate the insulin therapy and monitor the blood glucose and electrolytes as discussed before. And wait until DKA resolution. So here, the point I would like to stress here is you cannot monitor the serum bicarbonate or the urine ketones for the resolution of DKA. Those are not reliable. Why? Because in this case, it is the anion gap. So the decrease in the anion gap should be the marker for DKA resolution, because bicarbonate to regenerate, it takes time, and urine ketones, as we discussed before, it is only the beta hydroxybutyrate which is worrying. That, however, the patient will have acetoacetic acid and acetones which persist more than a day. Even after the correction of acidosis, ketones persist. And other thing is monitoring of delta ratio. What is this delta ratio? It is the ratio of anion gap excess to the bicarbonate deficit. So the measured anion gap minus 12 divided by 24 minus measured bicarbonate. Here it is 0.78. Usually the delta ratio, if it is 1, then it is the pure high anion gap metabolic acidosis. If it is more than 1, then there is coexisting metabolic alkalosis. So here in this case, there should be, with correction, there should be, the ratio should be less than 1, even towards 0.1. Otherwise, this suggestive of a hyperchloremic metabolic acidosis. Since we are resuscitating this patient with saline, there is a chance that hyperchloremia can happen, and it coexists with the high anion gap metabolic acidosis. So these are the pitfalls with respect to the lab assessment of your acid base. So what you normally expect is high anion gap metabolic acidosis, but you can get hyperchloremic metabolic acidosis, as we discussed before. Two factors are responsible for that. One is patients with good urine output. Ketonuria can happen with good hydration and GFR, where chloride exchange happens, causing or contributing to hyperchloremia. Or with volume correction with normal saline, hyperchloremia can get added. If at all there is a coexisting metabolic alkalosis, as I said before, then it's a case of suggestive of severe dehydration or contraction alkalosis, or the patient might be having recurrent vomiting, or there could be a concomitant diuretic use in these patients. Suppose we discussed the compensation of respiratory alkalosis as well. If at all there is a exaggerated respiratory alkalosis compensation, which means this patient has infection, sepsis, or respiratory component like pneumonia. So the only measurement which is diagnostic of underlying metabolic acidosis is the presence of high anion gap. And during treatment, focus on the decrease in the anion gap or the narrowing of the delta ratio. Now coming to the case scenario 3, it's a 48-year-old man, again type 2 diabetes with metformin.
Dr. Balachandar,
Sir?
we have to allot some time for discussion also.
Sir.
Thank you.
So this is a case of euglycemic diabetic ketoacidosis. A similar management. Only thing is here the patient is on sodium glucose cotransporter inhibitors and euglycemic. The blood glucose level is less than 250 milligram per deciliter. So the point I would like to mention here is the complications associated with the diabetic ketoacidosis itself. So I would like to say, due to the disease or the disease process, there can be exaggerated, sepsis, myocardial infarction, and renal failure, which can worsen the treatment or delay the recovery of the patient. And there are also therapy-related complications which can happen during the management of these patients. The focus is on cerebral edema, hypoglycemia, and hypokalemia. So by proper monitoring and several other measures, it can be prevented. And late complications, as I said, because of over resuscitation with normal saline, non-anion gap metabolic acidosis can happen. And these patients are prothrombotic and DVT, at risk of DVT. So these are some of the measures during the therapy which you should follow to prevent the therapy-related complications. Slow reduction of osmolarity during the therapy, avoid half-normal saline, which is hypotonic, and hyperglycemic correction within the accepted range, which is 50 to 75 milligram per deciliter per hour, prevent hypokalemia, and do not allow sodium levels to fall during the therapy. Avoid unnecessary bicarbonate therapy. The take-home message Again, the diabetic ketoacidosis with the complex pathophysiology. Remember, hyperglycemia and ketoacidosis are the characteristics, features contributing to the clinical manifestation. Promptly recognize, diagnose, and initiate treatment. That is crucial. Rapid recognition and initiation is going to save the patient. And be aware of the pitfalls with respect to the electrolyte measurements and metabolic acidosis. And follow the guidelines for the management, but individualized to the patient with respect to insulin therapy and electrolytes and IV fluids. Continuous monitoring of the metabolic and electrolyte derangement is essential and required for the proper management of this patient. And do not forget, in our anesthesia practice, this ongoing care should be continued intraoperatively as well as in the postoperative phase for the improved outcome. And be vigilant for the potential complications like cerebral edema and hypoglycemia. At the maximum, try to prevent them. Thank you.
Thank you, Dr. Balachandar, for a wonderful discussion. Now, Dr. Muthukumar has asked a clarification. I will split into two, one to Dr. Balachandar and one to Dr. Parthasarathy. So first to Dr. Balachandar, whether we do urine acetone or plasma acetone to diagnose diabetic ketoacidosis, especially in case of emergency.
Yes, sir. When the blood sugar levels are elevated, we always measure the urine ketones, if possible. I mean, in the given setup, we measure the urine ketones. But then I said earlier that urine ketones measures only the acetoacetic acid, and it does not reflect the beta hydroxybutyrate, which is the main culprit with respect to DKA. When you take DKA patients, beta hydroxybutyrate levels are higher than the acetoacetic acid. That redox reaction shift to the right side. And therefore, urine ketones does not measure the beta butyrate and does not quantify the severity as well. But it says that acidosis is present.
Excuse me, Dr. Balachandar, you have clearly mentioned it in your lecture. That is a redox reaction. It shifts the equation to the right. So it measures only acetoacetic acid. Now, as a practitioner, he wants to know whether plasma ketone is mandatory. Because we have to answer his questions.
For making the diagnosis, you can do, but for monitoring and assessing the decay resolution, it is not the reliable marker.
Urine ketone. You insist on plasma ketones.
Yes, sir.
So, can I put this question in favor of Dr. Muthukumar, whether we can do urine ketone? If it is positive, we can take it as ketosis. If the urine ketone is not positive, then we have to test for plasma ketone. The idea of me asking this question is, urine ketone can be performed anywhere in the laboratory. It can be even tested by doctors. But the plasma ketone cannot be done by all the people. It requires some sophisticated equipment. So can I make this question like this? Do urine ketone. If it is positive, okay, you treat it as ketosis because we want to anesthetize the patient. If the urine ketone is negative, and if you strongly suspect ketosis, go for plasma ketone. Will that be the right answer? Or you want to differ?
No, sir. If urine ketones are negative and plasma ketones may not be positive, sir. Because still the acetoacetic acid will be present in the blood and still it will be present.
Plasma ketones can measure beta hydroxybutyrate.
Yes, sir.
Then that is a possibility. Urine ketones, they strongly measure acetoacetic acid.
Yes, sir.
Plasma ketones, even beta hydroxybutyrate can be measured by plasma ketone, which is not possible in urine ketone if the level is low.
Sir, DKA patient, both acetoacetic acid and beta hydroxybutyrate will be present. So,
urine. So in other words,
urine ketones being negative, you cannot have a positive serum
That's
ketone.
what. Then urine ketone is sufficient to diagnose diabetic ketoacidosis.
Yes,
That's
sir.
what is question. To anesthetize a patient, urine ketone.
Sir, that's what I said. Urine ketones can be used to make the diagnosis.
That's
but
enough. If he is asking only that to make a diagnosis, that is the reason why he is asking only that. Now,
yes,
the second part of this question goes to Dr. Parthasarathy. Dr. Parthasarathy, the blood sugar is 350. Patient is having a gluteal abscess with ketotic breathing. That is acetotic breathing is mentioned as ketotic breathing. So it is an emergency surgery, IND. What is the anesthesia of choice?
Anesthesia choice is different, whatever it is. Depending upon your surgeon speed, we can go for spinal or some sedation or whatever it is. But get down your asymptotic breathing, get down your sugars, get down your potassium. You may take 4 to 6 hours, it is okay. It is not that urgent, what he said like that, breathing like that. So we can wait for 4 to 6 hours to get down all your metabolic abnormalities down, your sugar down. Then we can go up with whatever choice you are familiar with and your surgeon is acquaintance with.
So I think you have answered the question. Now I want to ask a specific question, as you are both of you are involved in that study. You said 6 ml of local anesthetic is enough to perform a sciatic nerve block. Now, just I ask, out of curiosity, I want to know how you have designed that study, whether you have come down from 20 ml to 15 ml, 10 ml. So in that case, if you are reducing that, whether any patient has suffered acute pain or you have done with the catheter technique. Because ethically, I think if you are reducing the dosage ml, what will happen? What had happened if when you have gone to 5 ml or 4 ml, you have fixed it as 6 ml? So out of curiosity, I am asking. How you have designed the study?
Sir, it is a biased coin design. Sir, shall I, sir?
Yes.
Yes.
Sir, it is a biased coin design method where we started with a fixed volume, which we routinely use. And then if first patient...
What is the ml you have used? That is my question.
We started with a 10, sir.
10.
We started with a 10.
And then if the first patient it is successful, then the next patient we will reduce the dose by 2 ml, sir. So in that way we have done. Suppose if we give 6 ml or 5 ml, 6 ml in some patients it was not working also. But finally the statistical volume which has come significant was close to 6 ml. So in that case we changed the anesthesia plan. We given spinal or we manage the case that way.
Yeah, that is why. So whether you have gone to 4 ml.
Yes.
You have gone
to
4 ml also.
Yes.
I
have
think
gone to 4 ml. There was some failure. There was some pain.
The professor is accepting. The professor is accepting. Associate professor is not accepting that.
Yes, sir. There was some pain.
Sir, 6 ml itself there was a failure.
Okay. Then thanks. I think it is a wonderful discussion. Dr. Parthasarathy and Dr. Balachandar has covered it extensively well, because Dr. Parthasarathy has extensively covered about the drugs, oral hypoglycemic agent and insulin involved. See, there are variety of insulin. Even anesthetic should undergo a CME on insulin therapy, because we have to know how many insulin they can use right and left. The problem comes, first he goes to the physician or the diabetologist, then he is landing up in surgery. So we have to read all the drugs, whatever may be the gliptin, whether it is sitagliptin or ramagliptin or krishnagliptin. We have to read all the gliptins, and every trade name we have to know. That is a problem. If it is a pharmacological name, it is very easy for us. So now the anesthetists are facing danger, actually, I used to say, in oral anti-diabetic therapy as well as the anti-platelet therapy. So many anti-platelet agents have come. So we have to be very thorough with the pharmacology. Then Dr. Parthasarathy has clearly mentioned about the HbA1c. It may not be useful for assessing the patient, but assess the end organ damage, it can be used. Same way he has designed it. That is my favorite part also. The major surgery and minor surgery, as far as diabetes is concerned, it depends upon the food intake. Then he has talked about autonomic neuropathy. He has put up a heroine slide also to stress that autonomic response. So that will elicit more of a sympathetic response when we have seen the slide. And he has mentioned about serum potassium value, because the baseline value will be useful. Then he has tightly described about the tight regimen and the non-tight control regimen. He has very clearly explained. Then the sliding scale he has mentioned, Miami sliding scale. Some people are using the scale as blood sugar divided by 150 is the basic insulin therapy, and blood sugar level divided by 100 is the baseline therapy. If the patient is receiving steroids or concurrent illness. But what I want to say, it is my personal opinion, this hyper and because he has mentioned the tight control, there is no botheration about hypoglycemia, that words he has mentioned. But for the youngsters, I want to say, at this juncture, even hyperglycemia is preferable than hypoglycemia. So never allow the patient to go for hypoglycemia, because there are so many important points in anesthesia. One is hyperglycemia is preferable than hypoglycemia. Hypertension is preferable than hypotension. So these are all the things we have to keep in mind. And whatever may be the disease, whatever may be the drug, always do blood sugar level 30 minutes before surgery. That will help you to monitor and maintain the case. And he has also mentioned about that neuropathy, because in the neuropathy, even in elderly patients, because of loss of subcutaneous fat, they are easily prone for compressive neuropathy. And in peripheral neuropathy, diabetic patients, we have to document, because medico-legally, if you give a central neuraxis block, sometimes you may be sued for the peripheral neuropathy. So that also he has mentioned very clearly. So this diabetic ketoacidosis, see, he has taken full 40 minutes to describe about diabetic ketoacidosis. That is extensive discussion on that. So the philosophy behind the diabetic ketoacidosis management is first establish normovolemia. So treat hypovolemia, then go for insulin regimen to bring down the blood sugar initially to 250 level. Till that time you use non-dextrose fluid. Then after 250 use glucose with insulin, then potassium supplementation. And he has correctly mentioned bicarbonate should not be touched immediately in a case of diabetic ketoacidosis. So we have to be very careful with that. And with the case-based scenario, he has discussed about acid-base imbalance also, high anion gap acidosis also. So it is a very good workup by this duo, Dr. Parthasarathy and Dr. Balachandar. So for this sweet webinar, we have to thank Indian College of Anesthesiology. That is, the trio are there in the screen. Dr. BRK, Dr. Jayashree Sood, and Dr. Sanish. So we have to thank them profusely, and we have to thank all the delegates who have sincerely attended this program. So I personally thank the two speakers also. And now it is over to Dr. Sanish, Indian College of Anesthesiology. Thank you.
Sir, a small question from the floor.
Tell me, sir.
Here, this particular diabetic ketoacidosis in relation to that thing. An elderly gentleman is coming, say around 80 years old, with the same gluteal abscess. Recently detected gluteal abscess. Patient is in very severe pain. A casual detection of diabetes mellitus or blood sugar of 250 or so. How long will you wait for this particular patient? And again, do you consider general anesthesia or subarachnoid or local block?
Dr. Balachandar, can you, the diagnosis, the clinical scenario was not audible to me.
Yes, sir. Clinical condition which he is
the clinical condition is not audible. We know that the patient
The
is
clinical condition is that patient comes with pain. On examination, the reason for the pain is the gluteal abscess.
Gluteal abscess. What is that, sir?
Gluteal abscess. Which
gluteal abscess.
Which you are discussing just now. And you
are
about spinal and all. That's why I was putting the question. You are considering a example of real anesthesia, and you are considering the same day spinal anesthesia and all. I'm telling you something. Well, somebody in very severe pain, patient is not able to lie on his back. That particular patient, well, a casual detection of diabetes mellitus is there, casual detection of something like 200 which is sugar level. How long will you wait, and what sort of drug you will use, what anesthesia you put to give?
Sir, let me intervene first. Dr. Parthasarathy has clearly mentioned he has not touched the type of anesthesia. He said that just because there is a impending diabetic ketoacidosis or there is a clinical suspicion of diabetic ketoacidosis, he said first you stabilize the patient condition and you can even perform general anesthesia or central neuraxis block. He casually remarked. Now Dr. Parthasarathy, please, sir is asking, blood sugar is 250. Abscess.
Whatever it is, whatever be the pain, yes, you give some fentanyl, get the pain down, take 4 hours to correct your metabolic abnormalities.
Right.
And give spinal or whatever it is, sedation or GA, depending upon your surgeon.
Yes. Agreed. Sir?
I'm hearing, but I am
Right.
not accepting that.
But you are in dark, sir. You are in dark. You have thrown light on us. You have thrown light on us, but you are in dark, sir.
See, that's correct. But I don't accept that particular view of Parthasarathy. That means waiting for that long. Unless this abscess is incised and evacuated, his condition is not going to become better. Well, you give something.
Sir,
Even if you
now you have thrown
because
light
it's a
on you, sir. Now
Yeah.
you have thrown light on you and also on us, so we are very happy. Initially, you were in dark. Actually, this is Dr. Parthasarathy's opinion because he feels like that. But what I thought when you were asking, just by holding a mask with the inhalation agent, immediately a nick will be done. But Dr. Parthasarathy was very specific in mentioning that depends upon your surgeon. So what I want to convey as a concluding remark, it could be IV sedation or IV anesthesia or inhalation agent or central neuroaxis block. There is no safe anesthetic technique. There is only safe anesthetist. You can practice butterfly stroke or a breast stroke or a back end stroke. You have to reach the shore safely. So SAR is also right because he wants to clear it immediately because once the abscess is drained, blood sugar levels will be easily coming down. Dr. Parthasarathy is also right because he wanted to stabilize the patient's clinical condition. So it depends upon the case-to-case basis, sir. So we cannot categorize. So both are right. That is anesthesia. So both are safe anesthesiologists. Both are concerned with the patient.
Yeah, okay. Then shall I request President Dr. Jayashree Sood to give order thanks? Madam, please.
Thank you very much, Dr. Radhakrishnan. So we've had a very, very healthy discussion and a lovely webinar on the sweet topic, as Dr. Meenakshi said, diabetes in the eyes of the anesthesiologists. Thank you so much, Dr. Parthasarathy and Dr. Balachandar, for that extensive description of diabetes and rightly moderated by Dr. Meenakshi, in which he stressed that we all need to know about the drugs, and it's very difficult, of course, and we don't have any of those books in which we can have a memory and you can just keep it in your pocket, the MIMS as they call it. But definitely, it is always useful to go on and find out which the drug is. And thank you so much. That was a lovely webinar. And thank you so much, Dr. Parthasarathy, although you're such a senior ICA member, but as Dr. Radhakrishnan said, this is probably the first time you have joined us. And thank you so much. Thank you, Dr. Meenakshi. We hope to see you again. And thank you, Dr. Balachandar. That was great. Thank you, Dr. Radhakrishnan. Thank you, Sanish and Vineet.
Thank you.
Hoping to see you all very soon in July in Delhi and September, Lucknow, and of course, next week. Thank you very much and good night.
Thank you, ma'am. Thank you all for giving me this opportunity.
Thank you, Balaji. Thank you. Thank you.